Good afternoon, everyone. We'll begin in just a few moments. Good afternoon. Today is October 9th, 2020. I am Darren Pruitt from the New York City Department of Health and Mental Hygiene. I'm the Deputy Lead for Stakeholder Engagement. Welcome to the New York City Department of Health and Mental Hygiene's COVID-19 vaccine update for New York City hospitals. Our topics today are considerations for COVID-19 vaccine planning and distribution, accessing the online registry, and completing the COVID-19 vaccination program provider agreement. We emailed this agreement out earlier this week to those registered participants. Our speakers from the New York City Department of Health and Mental Hygiene are Dr. Jane Zucker, Branch Director, Vaccine Task Force, and Assistant Commissioner of the Bureau of Immunization, Melissa Mickle-Hope, Unit Chief of Provider Quality Insurance and Deputy Director of Citywide Immunization Registry, and Dr. Bindi Crouch, Director of the Adult Immunization and Clinic Services. In a moment, Dr. Zucker will start us off. I ask each speaker to introduce the next speaker and that the audience hold questions until speakers have finished their presentations and we open the floor for discussion. You may also type your questions into chat and we'll get to those during the discussion period. A quick note before I turn things over to Dr. Zucker. Our webinar today will provide information and procedures specific to hospitals in the 5 boroughs of New York City. This information may not be applicable to hospitals outside the 5 boroughs, and those participants on our webinar today from outside New York City should refer your questions and concerns to your contacts within the New York State Department of Health. Our webinar today will be recorded, and we will post it to our provider page. At this time, I'd like to welcome Dr. Zucker.
Thanks, Darren. We're just working out the
okay. Hi,
sound.
Bindi.
Yep.
I'm here. Yeah, I'm sorry. I had to dial back in. I want to just thank everyone for joining today's meeting. The purpose is to share with you what we know about the planning in terms of CDC assumptions for COVID-19 vaccine planning and distribution. And so share with you what it is we know, what the expected timeline is, and then what we're asking the hospitals to do as next steps. So the next slide, please. Bindi, are you able to move the next slide?
Yeah, 1 second.
So just for the outline, I'll just very brief overview of where we are with vaccine development, important characteristics of the vaccines that are likely to be available first, and then talk about the planning assumptions. Bindi, we're back one.
I'm sorry.
Yeah, it's okay. Sorry, talk about the allocation and what we know about prioritization, and then again go to next steps for in terms of the online registry and completing the provider agreement. Next, please. So there are 6 vaccine manufacturers that have received funding from the Federal Program for Operation Warp Speed, and this is essentially to produce a COVID vaccine, and that's prior to licensure. So when a vaccine gets licensed, it can be used essentially right away. There are 4 vaccines that are in phase 3 trials in the U.S., and the purpose is to assess safety and whether the vaccines can prevent COVID-19 infection. So one is the Moderna mRNA vaccine, the Pfizer mRNA vaccine. These trials started at the end of July. The Oxford AstraZeneca DNA vaccine had started in August, but that trial is on hold for safety concerns. And then the Johnson & Johnson Janssen DNA vaccine recently started their phase 3 trial. Next. So because of, so when the phase 3 trials are designed to assess vaccine safety and effectiveness, they're all randomized, blinded, placebo-controlled trials. They're enrolling participants 18 years of age and older. Although Pfizer will begin enrolling persons 16 and older, there are no ongoing trials at this time in children. Those are planned for 2021. They don't include persons who are immunocompromised, although Pfizer will enroll people with HIV. And then it does not include pregnant persons or, as I mentioned, children. So FDA has issued guidance for licensure in terms of their regulatory expectations around effectiveness and the safety data they want to see. And then just this week, they posted additional guidance related to what data they would want to see to issue an emergency use authorization for the vaccine. And that includes having at least 2 months of safety data on at least half of the study participants. Next. So the focus is on the vaccines that are expected to be available first, and this is based on when their trials started. The first, again, is Pfizer mRNA vaccine. CDC refers to this as vaccine A in their planning materials. It's shipped at -70. The vaccine can be stored in their stored in their shipping container for up to 10 days, but it can actually be stored longer with replenishment of dry ice. The vaccine can be stored at 2 to 8 degrees for up to 5 days, and this is actually an update, as some of you have seen the previous presentation where it was indicated that it would be frozen, but the 2 to 8 degrees is the standard vaccine storage refrigerator temperature. The vaccine will have a minimum order of 1,000 doses, actually 975 doses. The vaccines will come as a 10-dose vial and will require reconstitution. The Moderna vaccine will be shipped at -20, so that's frozen. That's how varicella vaccine is currently shipped and stored. And this vaccine, can be stored at -20, but once it's moved to 2 to 8 degrees, it can be stored there in a refrigerator for up to 14 days. And these minimum orders will be 100 doses. 5-dose vials that have no preservative or reconstitution. Next. So the assumption is that vaccine will be available either directly from CDC to certain federal sites and other federal partners, or through the New York City Health Department initially. For those of you who are around during H1N1, it was a similar process. And obviously with the storage requirements of these 2 vaccines, that the distribution will be limited by vaccine storage and handling requirements and capacity of the facility to handle the vaccine. We are expecting these will be 2 doses. The interval for Pfizer is 21 days and Moderna is 28 days. Just a sort of footnote that the Johnson & Johnson trials are looking now at a 1 dose of vaccine for effectiveness, and we'll also be looking at 2 doses. These are IM injections, and because they're different platforms, the products will not be interchangeable. And CDC will be shipping vaccine supplies, the vaccination supplies like needles and syringes, as well as some PPE. in a separate box, but along with the vaccine. Next. So the planning assumption from the CDC is that vaccine will be available in 2 phases. What they're calling phase 1 is limited availability of vaccine and would be for what they will determine as the highest priority group. And then what they're calling phase 2 is greater availability for the general public. So next slide. For the phase 1 assumptions, CDC has indicated limited supply for the country, and as early as November, they're saying initially 3 million doses and as much as 3 million doses and possibly 20 million doses by the end of the month. This would be a product that would be available under an EUA. And again, CDC would distribute to federal locations, for example, the Veterans Administration hospitals, and also CDC is establishing contracts with pharmacies, the big chain pharmacies, and they would be targeting long-term care facilities as one group. Again, because of the supply, we expect vaccine to be offered at a smaller number of sites that can reach the target population. And since we expect healthcare personnel to be among that first group, it's why our initial focus is on working with hospitals and large medical facilities to be able to vaccinate healthcare personnel. And at this time, we do not know what the New York City allocation will be in terms of the number of doses. Next. So phase 2 is when this would be a licensed vaccine. Again, could be as early as 2021. So this is greater availability for the public. And again, if production is, as I said, would be started before the vaccine was licensed, so it would be readily available. And we would see the vaccine distribution similar to the way we do for the Vaccines for Children program. So orders would come into the health department, which we would process and then have vaccine shipped. And so we're talking about broad distribution and availability. And we would really be relying on the existing vaccination infrastructure during this phase. And all of the sites listed here, are important, vaccination facilities, certainly for flu vaccine in the city now, and will be critical to the plan going forward. Next. So I just want to talk a little bit about allocation. And there are sort of 2 competing frameworks out there. One is ACIP, and that's the Advisory Committee on Immunization Practices, and they are responsible for the national vaccination guidance, and they are an advisory committee to CDC. And they've put forth their principles for guidance to reduce the health impact of COVID-19, reduce transmission, that any vaccine would need to be proven safe and effective, and that there's an equitable allocation and availability. They've been meeting regularly, and their recommendations are in development, and it's not expected to be finalized until they have a meeting the end of this month. And depending upon what vaccine effectiveness data and safety data is available, they will not be making formal recommendations at that October meeting, but this is the earliest we would see something from them. Next, their initial sort of priority groups that they've been thinking about that's been presented at the meetings have been healthcare personnel and really focus on those with high risk of exposure. And they're using, the definition of healthcare personnel are really all people who are working in the facility, so not just the professional staff, but also people in food services, security, engineering, janitorial services, thinking about people who have risk of exposure to COVID aerosols or environmental exposures, in addition to direct patient care. They also are talking about persons with increased risk of COVID complications, so people who are 65 and older, people with high-risk medical conditions, as well as sort of high-risk settings like long-term care facility staff and residents. And then they've also been talking about essential workers, although this has been less well-defined. Next. So the other competing framework is from the National Academy of Sciences, Engineering, and Medicine. This framework is supposed to sort of help guide the ACIP deliberations. And this group is made up, there's scientists, ethicists, clinicians, public health practitioners, and community members. And they've set forth as their goal to reduce severe morbidity, mortality, and negative societal impact from COVID. and their allocation criteria is based on risk of acquiring infection, risk of severe morbidity and mortality.
Hi, Dr. Zucker. It looks like you accidentally muted yourself. Oh.
Yep, I just saw that. Sorry about that. So just go back to the allocation criteria. So they've highlighted risk of acquiring infection, risk of severe morbidity, mortality, and the risk of severe negative societal impact, as well as risk of transmitting infection to others. Across all of their guidance, they really stress the ethical principles of maximizing benefit, equal regard, mitigation of health inequities, as well as procedural principles for fairness, transparency, and that any recommendation should be evidence-based. And they've sort of proposed 4 allocation phases that don't sort of align with the CDC phases, but roughly CDC sort of phase 2 with a lot of vaccine being available is roughly the sort of NASEM sort of phase 4. And they sort of give allocation framework, you know, for phase 1A, 1B, 2, and 3. And I'll talk about the 1A because that's what's most relevant to the initial discussion next. So for their 1A, they talk about high-risk healthcare workers. And so again, it's health professionals involved with direct patient care, as well as workers who meet risk criteria. Those could be, again, transportation, environmental services, nursing assistants, assisted living staff, long-term care facility staff, group home staff, and home caregivers, so people who are exposed to bodily fluids or aerosols. This group is sort of a bit broader than some of the ACIP discussions. And again, this grouping prioritized because of their critical role in maintaining the healthcare system and their risk of exposure to individuals who may have symptomatic or asymptomatic COVID. And again, their risk of transmitting the virus to others, including their own family members. And again, this is just regardless of professional title. Next. So the considerations, and there's one slide on this and then another way in terms of how we're asking the hospitals to consider their own, the vaccination plans for their facility is thinking about like which staff work directly with COVID-19 patients. Again, either direct care or cleaning, handling deceased bodies. NASEM also brings in mortuary services. You know, which staff are performing procedures with a higher risk of aerosolization? Are there staff who have uncontrolled exposure to patients or to the public? You know, can duties be consolidated to fewer people who can be vaccinated while supply is limited? And you would already be doing that in terms of cohorting your staff who are caring for COVID patients. And then also thinking about on the equity spectrum is are certain roles predominantly filled with staff who have faced sort of racial oppression or sort of social injustice that might place them at greater risk for exposure, morbidity, mortality, as well as transmission? Are certain roles in close contact with patients who are at greater risk of morbidity and mortality if exposed? And then how can facilities allocate, you know, and account also for your staff health as well in terms of those at greater risk if they got infected because of comorbid conditions? Next. So for the distribution, and you'll see more about the provider agreement, but all the facilities, whether it's a network or an individual facility, will be required to sign a federal provider agreement and to identify each of the vaccine site administration sites would be identified as well. So it may be, let's say, a main hospital as well as like other hospitals in the network or larger outpatient facilities. And we expect vaccine would be sent to the facility's main pharmacy. It may be to more than one pharmacy if you have a one hospital, you know, is in one borough and we need to ship vaccine to the pharmacy in a hospital in the network that's in another borough. But your plan needs to really think about the entire healthcare system and network, including ambulatory sites. One thing that was very confusing during H1N1 is that all of the different sort of clinics and faculty practices ordered H1N1 vaccine, but it all, of course, went to the same pharmacy. And so the sort of redistribution was confusing. So we are asking the hospitals to plan for all of their clinics and family faculty practices as well, because again, the vaccine is going to go to the main pharmacy and then, would be distributed, or, it may only be one clinic that's going to be provided because of the storage requirements. We're asking you to include the EMS services that are connected with your hospital, and then also start considering your plans to vaccinate your patients, and then, whether, opening it up for the general public, since there may be limited sites where the vaccine can be offered. Next. We're going to talk later a bit more detail about the citywide immunization registry. All right, all vaccines that are administered to children are reported to our registry, and adult vaccines can be reported with consent. So all the hospitals that are administering pediatric vaccines are all connected to the registry already, we'll talk about how you can assess like who's your administrator for the registry, and if you are connected to the registry later. But the provider agreement will be available and completed and signed in the registry, so it's all going to be electronic. Vaccine can be ordered by an online ordering system that will also be in CIR. For the pharmacists who would in your facility who are ordering the Vaccine for Children program, they would be familiar with that, or the vaccine coordinator. That's how we do the pediatric vaccine. The health department would review orders and then approve them. And, we would expect, because of limited supply, that initial shipments likely to be partial shipments. What we do is that order comes into the health department, we process it, it goes to the CDC via their application, which is just called VTRAX, which is again used for pediatric vaccine, and vaccine will be shipped directly to the facility. It's either the frozen vaccine would be sent from the vaccine manufacturer, or from the other vaccine that's refrigerated would be sent from the CDC distributor. And we do expect that reporting of all COVID vaccine doses will be required. That was similar to what happened during H1N1. Next. So again, we want you to start planning now, thinking about how your facility will allocate your initial doses of vaccine. If you only get vaccine for 10% of your staff, who's going to get it first? Thinking about who are your highest risk healthcare personnel, who are those at higher risk of severe disease. How are you going to vaccinate your patients? Checking on whether you're registered with CIR, and if you're already reporting adult vaccine doses to the registry. So next. So I'm going to turn it over to Melissa Nickel-Hope, who's the Deputy Director for the Citywide Immunization Registry in the Bureau of Immunization. So take it away, Melissa.
Hello, can you guys hear me?
Yes, we can, Melissa, thank you.
Great. Bendy, you can go to the next slide. Okay, so as Dr. Zucker said, access to the CIR online registry is necessary to complete the COVID-19 vaccine provider agreement. Additionally, the COVID-19 vaccine ordering will be done using the online registry. So it's important that you all are able to access the online registry. Currently, each hospital has a CIR online registry site security administrator. That administrator can set up accounts, a username and password for access to the online registry to as many users as necessary. Now, in your Vaccine for Program site, the vaccine coordinator or pharmacy director would have knowledge of the online registry and may have knowledge of the SSA. If you, again, those are pediatric programs, if you would need access, you can get it through that SSA, which may be a pediatric person, or you can set up an account for your adult clinic. So that's something to keep in mind. But currently, at least the pediatric sites have access to the online registry and have an SSA set up with us. Now, you may request online registry access from the CIR directly. If your site, if your adult clinic does not have access, you can create that by filling out 2 forms and emailing it back to us or calling our hotline, which is 347-396-2400, listed on the slide. Please include your CIR facility code over the phone or in the email body so we are able to assist you with that request. And next. Next will be Dr. Bindi Crouch that will review the provider agreement and provider profile necessary for the COVID-19 vaccine program.
Okay. Good afternoon, everyone. And again, thank you for joining. I'm going to review the provider agreement that is required to order, receive, and administer COVID-19 vaccine. So you all should have received an electronic copy of the agreement. This will be completed online. However, you should use the distributed copy to review the questions and collect the information. So the agreement is divided into two sections. Section A is the provider requirements and legal agreement, which you will complete one per network. Section B is the provider profile. You will need to complete one provider profile for each vaccination site. So Section A includes the agreement requirements and will require e-signatures from both the CMO or equivalent and the CEO or the chief fiduciary. And by signing the agreement, you will be agreeing to administering vaccine in accordance with the ACIP guidance, reporting administered doses within 24 hours to the immunization registry. You will be agreeing to adhere to the billing requirements that your institution will not seek reimbursement for vaccine or supplies provided to you by the CDC, and that your institution will administer vaccine regardless of a recipient's ability to pay a vaccine administration fee. You will also be agreeing to adhere to vaccine storage and handling requirements, as well as inventory management requirements. And finally, you'll be agreeing to adhere to requirements to report adverse reactions to the National Vaccine Adverse Events Reporting System, or VAERS. Section B is the provider profile, which again will need to be completed for each vaccination site. Here you will be required to designate a COVID-19 vaccine coordinator and backup coordinator. And information in this section will include shipping location and hours, size and type of population served, the type of facility that you are, your vaccine storage capacity, as well as provider information. And in addition to the questions found on the provider agreement and profile that we distributed, you'll find questions on healthcare personnel in your facility. And Dr. Zucker referred to the healthcare personnel. Here, I just want to point out the definition for healthcare personnel refers to all paid and unpaid persons serving in healthcare settings who have the potential for direct or indirect exposure to patients or infectious materials, including body substance, for instance, blood, tissue, and specific body fluids, contaminated medical supplies, devices, and equipment, contaminated environmental surfaces, or contaminated air. So these healthcare personnel may not be directly involved in patient care, but potentially may be exposed to infectious agents that can be transmitted among healthcare professionals and patients. And I just want to add here that institutions will need to also consider any medical students or residents, as well as contracted employees that may be rotating at or working in their facilities. So as part of the provider profile, you will see questions about your healthcare personnel. So the first would be the total number of healthcare personnel at your facility. And then we will be asking the number of healthcare personnel with a high risk of exposure to COVID-19. So this brings us back to what Dr. Zucker had spoken about previously. And specifically, we'll be asking about the number of ICU personnel, the number of emergency department personnel, and the number of other high-risk exposure personnel that are not captured in A or B. Importantly, within this group, we would like you to include your emergency medical services associated with your institution. And then finally, you would total that number to come up with your healthcare personnel with high risk of exposure. So here's some contact information. This is the same contact information that Melissa provided for the CIR. We have the CIR hotline as well as the email address. And then if you have questions about the vaccination program in general or about the content of the provider agreement, you'll be able to contact me, and I've listed my email address here. And so I want to thank you again for attending our presentation. And it looks like we have a fair amount of time to review questions and have some discussion. So I'm going to turn it back to Darren.
Yeah, so it's Jane. If I could just make a few comments before we open it up for questions, which I suspect there would be many. So I know that that provider agreement may sound like a lot, but it's not dissimilar from what's already in the provider agreement that's signed for the Vaccines for Children program, and also follows a similar sort of content to what was required during H1N1. So, there is, a lot of the information in there is obviously critical. We can't ship vaccine if we don't know what the storage capacity is that a facility has, as one example, and that's information that's routinely provided through the Vaccines for Children program, although we obviously don't ask about ultra cold storage. So it may look like a lot, but it's very consistent with other past agreements. And also, as far as the healthcare worker definition, I would expect that you're all fairly familiar with it, because it's not, again, dissimilar for what CDC uses through NHSN in terms of reporting flu vaccine doses, currently. So that's just in terms of some more context. If we can open it up for people, I'd love to hear from the hospitals on the line if they have any questions or feedback.
Thank you, Dr. Zucker. This is Darren again. I do see some questions in our Q&A section of the WebEx window. If you do have questions, continue to type them in the Q&A section. Our first question comes from Susan Donnellan. Do you have any sense as to whether persons who have already been diagnosed with the infection will be lower on priority lists and will get access to vaccine with the general population, or will they have access based upon their job function?
Okay, so it's Jane. So we expect access will be based on job function. So far, none of the recommendations that I've seen take into account whether someone's had a prior infection.
Our next question is from Eric Applebaum. Does the vaccine coordinator need to be LIP?
I'm sorry, what's LIP?
Mr. Applebaum, if you could type that in for us so we can clarify that. I'll move on to the next question. From Alexandra Grisas, what has been the discussion around mandating the COVID-19 vaccine?
So that's a very popular question. One, I would just say at this point we don't have a licensed vaccine product, and we don't have even an EUA. I don't think anything would ever move forward in that direction without having a licensed product with a proven safety track record. I think that will probably be a discussion, for sometime in 2021, whether it would follow the flu requirement that the state has in place or not. But I think it's way too premature for that discussion. And again, I would not expect that at all without a licensed product. And you also need sufficient supply to even consider that. Next.
We have clarification on LIP, that is licensed independent practitioner. So I think the question was, does the one registering for the CIR need to be a licensed independent practitioner?
Yeah. Melissa, do you want to answer that? Again, most hospitals already will have a CIR account, and that people who would sort of have access now would be the pharmacy that may be ordering it, the VOC vaccine coordinator, as well as the staff who are involved with vaccination.
Well,
so
hi, this is Melissa.
Yeah.
Yeah, we know that coordinator does not have to be
right.
a license. No.
Right.
But
Thank
just to
you.
reiterate what Wendy said, that to sign the agreement, we do need the CEO, the CFO, and we do need a third signature from the vaccine coordinator or pharmacy coordinator.
Right. So it's a CMO plus either the CFO or CEO, right, and the vaccine person. So the CMO is sort of critical to initiating the process.
Our next question is, when would you expect hospitals to sign up in the CIR with adequate time for vaccine allocation planning?
So the provider agreement that we're talking about is already, we're just putting the finishing touches on it in the CIR, and our expectation is that we'll actually launch it next week. So it will be available to start, signing the agreement, and we would hope that hospitals would really start registering for vaccine next week and to start their planning now.
And they'll receive a notice once it's up and available.
Yeah.
Thank you. Will there be a way to access vaccination data from the CIR for our employees?
So I'm not sure if the question, so one, we would, the hospitals will be required to enter all the data on their own employees, into the CIR. Again, that any COVID vaccine that's administered will be required to be reported to the CIR. We expect the regulatory changes to be made to require that and to waive consent. So the beauty of the CIR is that if you do have healthcare workers working at more than one site who get vaccinated on another site, you will be able to look up those people in the CIR. Many of the hospitals do have bidirectional connections with the registry. So depending upon what EHR you're using sort of for your employees versus like the patients, certainly on the patient side, you're able, if you have bidirectional connectivity with the registry, you can actually like kick off a query out of your EHR and actually search, for the person and bring in that vaccination data into your EHR. So that would depend on, again, the system you're using in employee health, and as well as whether you have a bidirectional connection with the registry. And if you don't, we sort of strongly advise, that you take steps to put that in place. Again, a lot of the pediatric, if you have a pediatric program, you most likely have that already.
This question seems to be very much related, and you may have answered it, but I'm going to state it for you. Will there be a waiver of consent for CIR in order to allow submission of data for all vaccinations given as required in the agreement?
We expect that to happen. That happened with H1N1, and so, I'm confident it's going to happen again for the COVID vaccine. So no consent and then requiring reporting. We expect regulatory action at the state level and, followed, by immediate action by the city and Board of Health.
Thank you. If a site also fills out a CDS supplemental redistribution agreement, does the site still have to fill out Section B for each vaccination site?
Hi, this is Melissa. Yes, it will. Now, the one thing about the supplemental redistribution agreement, we're going to be dealing with that directly with the Bureau of Immunization, so we would not have that posted through the online registry. that will be approved on a case-by-case basis and dealt with directly through the program.
Thank you. Our next question is, will there be a vaccine information sheet to distribute upon administration?
The answer is yes. CDC will be developing that and will be providing that. There'll either be, a vaccine information sheet like a VIS like we're used to with vaccines, or there'll be an information sheet that would go along with a vaccine that was available through an EUA. We are expecting a lot of training materials to come from CDC, including videos, for example, how to handle the Pfizer vaccine, the storage, how to reconstitute it, et cetera, all of the different steps. So I think there'll be a lot more materials coming in the next few weeks.
Thank you. The next question is, will there be any plans to have pharmacists help administer these vaccines at facilities? Yeah, so I think that's a hospital decision on who they're going to have actually do the vaccine administration. Pharmacists are authorized to administer COVID vaccine under the PrEP Act. They're also eligible, to offer, regular vaccines in the facility, based on the New York State law, and if the pharmacists have an appropriate certificate of vaccination. So, I think that pharmacists may be very, important part of the of a hospital's plan. We do expect pharmacies sort of outside of a hospital, for example, whether it's a chain pharmacy, to also receive vaccine, although it's not clear exactly when, like they're not going to have vaccine in that sort of phase 1A period. But as there's more availability, I would expect there to be vaccine available, at chain pharmacies, and then also at, independent pharmacies as we get more supply. Thank you, Jane. Will one hospital in a health system be designated as the main facility to receive drug product for all hospitals and clinics across their entire health system?
Yeah, so I think that's, in part a decision by the network. We don't want, if the vaccine is being stored at -70, we don't want redistribution. So I think that's partly where we can work with a facility, and I think it depends on the size of the hospital and where the other hospitals are located. So if there's a main facility, let's say in Manhattan, there's a large staff, makes sense to send vaccine to that facility. But again, if the network has a large facility in another borough with a lot of staff, to me, it would make sense to have vaccine shipped directly to that other facility, to be able to vaccinate the staff who are affiliated, both inpatient and outpatient, with the hospital that's in the borough. So, again, I think that's part of the planning with that the hospital needs to do, and it's, certainly something that we can have follow-up discussions on, to discuss particular scenarios for a given hospital and/or network.
Thank you. Our next question is, to assist with planning, when will information regarding freezer, refrigerator, and room temp stability requirements be released?
So there's some summary information that I provided in this slide. We can certainly share what we know from CDC now, but even that's evolving. The storage requirements for the, for example, the Pfizer product have changed, and they're doing additional stability testing now to see how long, their shipping container will last. But I think, this is what you could expect. Pfizer it will be shipped at -70. I know the shipping container, you can use it. You'll have to replenish it with dry ice within 10 days. And if you want more, and you can clarify, I mean, we've been given some information, like it's 23 kilos of dry ice to replenish it. If you want that level of detail, we can provide that separately. The 2 to 8 degree storage here for 5 days. So this is important because you need to plan to use the, if you get 1,000 doses, you need to be able to use the 1,000 doses within this timeline. The Moderna is more straightforward because you can store it at -20 if you have adequate freezer space. Again, that's the same temperature that you would use for varicella vaccine. And so you have more time to store it at the -20 before you would need to use it. And then you could move vaccine to sort of 2 to 8, as you plan different vaccination clinics and as you see how fast you go through your supply. But if we can have, if we can just get information about what more detail would be helpful for a facility, then we're happy to provide whatever we know and to double back with CDC to get questions answered that we don't have answers to.
Thank you. Now we have 3 questions related to the CIR. One is the follow-up to the data question before, and the respondent wants clarification that CVS, Walgreens, and other pharmacies are also submitting data to CIR, and it's not just hospitals and providers.
Yes.
Yes. So thank you for the question. I will just tell you that a lot of flu vaccine goes on at the chain pharmacies, and they're really good reporters. So, I mean, that's partly why we promote accessing the CIR to really all medical facilities, because it's a good source to find out if your patients have been vaccinated, and even your staff to some extent have been vaccinated, outside of the facility. And with a bidirectional connection, you can bring that data back into your EHR. But the chain pharmacies are really good reporters.
Thank you. The next question about the CIR is, if we already have an account with the CIR for pediatrics, do we need to open another account to report adult COVID-19 vaccinations?
Melissa?
Well, we are pretty flexible. If you are comfortable, we want the adult vaccines reported to us. If you would like to do it with the recurrent facility code, you can do that. But if you wanted to have everything put to an adult facility code, you can do that as well. Just remembering that the account you have is going to be used for COVID-19 ordering as well. So you'd have to go to the account, go into the online registry, and order COVID-19 vaccine. So based on how your workflow is set up, we're pretty flexible in terms of that.
Thank you. And the last question related to the CIR is, do individual ambulatory clinicians also need to be registered in the New York City CIR, or is their hospital sufficient?
The hospital is sufficient.
And let's see.
Yeah, I'll just make one. Yeah, that may change as that's a correct answer, but when we get to a time when there's a lot of vaccine available, we may ask the ambulatory care site to register separately so that vaccine gets shipped directly to them instead of the hospital. But I think, that's several months down the road.
Thank you. Our questions are turned back to the issue of stability and the freezing of the vaccine. The question reads, it's also helpful to understand, 1, once removed from the freezer, how long is the vaccine stable? 2, once reconstituted for the Pfizer vaccine, how long before it must be administered? And 3, how long must each thaw before administration?
Yeah, so what we're told, so first, after reconstitution, so things that the vaccine can, I think it was 30, and Bindi, correct me, 30 minutes for thawing of the Pfizer vaccine, but when it comes out of the refrigerator and you reconstitute it, it's 6 hours. The same thing for the Moderna vaccine. Once it's out of the refrigerator, you have 6 hours to use it. Anything that's unused gets discarded and is wasted.
Yes, that's what I believe, Jane, thanks.
Right. So what we'll do is pull out, we are in the process of putting up some of the, like the provider agreement, the link to the NASEM framework, putting those links up on our website for what would be a sort of COVID vaccine provider page. What we can do is also add the information that we know from CDC about vaccine storage and handling. Recognizing that may change. Whatever we know today may actually be different next week as we get updated information, but we're certainly committed to making sure that everyone has, the new information and updated information as we get it.
Thank you. At this time, we only have one remaining question, and that is November delivery of vaccines a projected date?
So the planning date that the health department's been given by CDC is a sort of November 1st, early November planning date for initial vaccine availability. And that is the planning assumption, recognizing that may also change, but that is what we're working with. And it's also why we do want hospitals to sign up and at least be ready to, receive vaccine if we do have vaccine, that is available, and has gone through the proper regulatory channels.
Thank you. It appears at this time that we do not have any further questions, and with 8 minutes remaining, I'd ask anyone, any participants who still have questions to type those into Q&A, or if I missed one of your questions, because they scroll pretty quick, retype it into Q&A, and I'll try to get it out to our panelists.
Yeah. So again, the next steps for hospitals, we'll send, the provider agreement was sent along, after the invitation, but to everyone who received an invitation for this call. So you can see the provider agreement in terms of the information that we need to be completed. If you have questions, we have, this is the contact information. We're happy to answer additional questions. And then the next email would come when we have, once the provider agreement is up in CIR, notifying hospitals that they can go into CIR and start completing the agreement.
Thank you. We do have two more questions. If health systems have hospitals outside of New York City, for example, Westchester, will those outside of the city receive vaccine from New York City or their own health department?
So they would receive vaccines from New York State allocation. We recognize that there's a number of facilities in that situation, and the city and state are in regular contact, and we've been coordinating our efforts. And so we would plan to make sure that the facility is appropriately receives vaccines.
Thank you.
So we're aware of that concern. Yeah.
Thank you. Our last question is, can sites start to submit the CDC provider form now? So it has to be done electronically. So you can't submit it now. You have to wait till it's launched in the registry next week, and we'll notify you as soon as that's available. There is a lot of information required, so I think starting with a hard copy of the provider agreement we set will sort of help you plan, so you have the information ready to complete the agreement. Again, you're going to need 3 signatures, so that's also you can plan for that now.
Dr. Zucker, do you want me to just give an overview of how they would sign it electronically, just an overview of how it would work?
Yes.
Okay.
Do that.
So
yeah.
So once we launch on the online registry, we will send you an email letting you know that the form is available. You'd log into the online registry, and we have a COVID vaccine program section set up already. And the person that will be in charge of getting the signatures on the form would click on the invite button. There's a button that says invite me to begin the process of completing the COVID-19 vaccine agreement. So please let the person in charge of getting the signatures, again, there's 3 signatures, that person would click the button and receive an email link to start the process. And we would go through the process of completing the agreement through our online system. Okay, so that's why it's important that the person in charge of getting the signatures have access to the CIR online registry. Once the process started, you can invite others to collaborate on the form. They will receive a link in their email as well, and they can access the form, complete the required section, sign the form as necessary. Okay, so one person initiates and collaborators.
Yeah, sorry, thank you, Melissa. So one of the things, once we launch the provider agreement, we're happy to have another meeting like this where we can actually walk people through, and do a demo of the system. It's actually going to make everyone's life a lot easier and quite straightforward, but we're happy, to set up a time to do the demo once we've launched the online system. I think that might be helpful.
Thank you. At this time, we do not have any further questions except a request for the slides and the recording of this webinar. These will be posted to the provider page, and we can send that link out to all registrants because we have your email address for this webinar. I'd like to thank the panelists and all of our attendees, which numbered around 140 at one point during this webinar, and wish you all success in the fall and this coming vaccine season. Thank you all. This concludes our webinar today.
Thank you very much, Darren. Thank you, everyone.
Yeah, thank you, everyone, for participation and also for the great questions. We appreciate it.